Nutrition strategies for stress fracture recovery. Injury of choice, a stress fracture. A stress fracture is an overuse injury of the bone that is caused by the rhythmic and repeated application of mechanical loading in a subthreshold manner. Stress fractures account for 15 to 20% of all musculoskeletal related injuries. This is the most common injury in endurance, athletic, and weight class sports. There are risk factors that are biomechanical, such as training pattern, bone characteristics, and anatomic considerations, and biological risk factors that make up female gender, genetics, medication, dietary contributions, and the female athlete triad. There are three components of the female athlete triad: low energy availability with or without disordered eating, menstrual dysfunction, and low bone mineral density. Research has found that females with one component of the triad are 2.5 times greater at risk for developing stress fractures compared to athletes with no components. Females with two or more components are 4.7 times greater at risk for developing stress fractures. There are consequences to the injury, such as pain, medical expenses, reduced performance, and loss of training time. The table to the right is a representation of reduced performance. As you can see, the stress fracture group had a reduced knee extension strength by 18.3% compared to the non-stress fracture group. As far as nutrition strategies, you want to make sure that you're consuming adequate total energy and intake, which can be achieved by 45 kcal per kilogram lean body mass per day, and avoiding reducing energy availability to less than 30 kcal per kilogram lean body mass per day. You want to make sure that you're consuming appropriate dietary intake by meeting 1.6 to 2.4 grams per kilogram lean body mass of protein, and making sure that you're having 20 to 40 grams of protein pre and post exercise. Consuming carbohydrates to meet the demand of the sport, which is roughly 55% of total calories. Additional considerations would be correcting dietary deficiencies, which can be achieved by supplementation, such as vitamin D at 800 to 1,000 IUs per day, or calcium at 1,500 to 2,000 milligrams per day. Calcium and vitamin D supplementation has been shown to reduce the incidence of stress fractures by 20%. An additional supplementation to consider would be a carbohydrate protein mixture. This adds calories, carbohydrates, and protein. Research saw that it can reverse exercise-related menstrual dysfunction after 6 months of supplementation. This slide is about important nutrients for bone health, such as phosphorus, potassium, manganese, boron, and zinc. The reasoning behind the nutrition strategy is that low energy availability and lack of nutrient intake may lead to vitamin and mineral insufficiency. Research saw that energy availability of less than 30 kcal per kilogram lean body mass was associated with reduced bone formation, and energy availability as low as 10 kcal per kilogram lean body mass per day was associated with reduced bone formation and increased bone resorption. This fascinating fact below says that bone metabolism was not affected when low energy availability was attained through exercise, but consumption of adequate intake was achieved. Additionally, hormones are affected by low energy availability, such as leptin, estradiol, and an insulin-like growth factor are reduced, and cortisol is increased. This hormone imbalance decreases osteoblast activity and increases bone resorption, affecting bone mineral density. Additionally, consuming adequate protein is vital for bone structure as it makes up significant proportions of mass and volume of bone.